Welcome back, everybody. This is the second session of day two. This session is on implementation of the Sheikh Khalifa Stroke Institute model of care. Um, and our first speaker is going to be Pei-Ting Lien. She's going to talk on organization of stroke care across the continuum. Dr. Pei-Ting Lien is a doctor of physical therapy, and she's a neurological clinical specialist. She's the outpatient program manager for the Sheikh Khalifa Stroke Institute, and she has been instrumental in figuring out a strategy to organize the stroke care and implement it across the continuum, bridging all the various silos that we talked about. So without further ado, Pei-Ting Lien.
Hello and welcome. My name is Pei-Ting Lien. I am a physical therapist by trade, a clinical specialist, and currently the outpatient program manager for the Sheikh Khalifa Stroke Institute. Today, I am here to share with you on the organization of stroke care across the continuum. I have no disclosures. The objectives of my talk today are to outline an implementation strategy for the SKSI model, as well as the harmonization of patient-centered goals and team objectives to facilitate a cohesive plan of care across the continuum of care. I will also detail the outcome selection process in determining appropriate screening and functional outcome measures to be tracked during each stages of the SKSI program. To start, the graph of this slide is to depict the contrast between current model of care versus the desired model of care. Historically, the focus of rehabilitation process has been on the triage of patients and how to move them through the continuum of care as quickly as possible instead of recovery. This is often dictated by the length of stay within each settings, as well as insurance limitations. As a result, the least impaired patients typically receive more intense therapy, while those that are most impaired often receive the least intense form of therapy, also requiring longer length of stay in a rehabilitation setting. But not all patients are ready for the high intensity at the beginning of their rehabilitation process. Thus, the desired model of care strives to meet them by offering the right treatment and intensity at the appropriate time. In order to shift from the current care focus mainly on moving patients along the continuum of care versus recovery, we needed a new model of care for recovery and rehabilitation. Here you'll see these circles. Now, each circle highlights the crucial components of this new model. This includes the integration of care across levels, building an outcome database, developing algorithms for precision rehabilitation, disseminate through a learning network, as well as demonstration of effectiveness of this model. Today, I will focus on the highlighted red circles of these components as we implement this into our care model. First, we had to identify what are the existing challenges and gaps to achieving our proposed new model of care. These challenges can be categorized into operational challenges, challenges in establishing consistent outcome assessments across each setting, and challenges to establishing treatment approach consistency. Ultimately, the implementation process needed to be fluid and adaptable as this process continues to evolve. Some operational challenges included siloed care, patients lost in transition, dosing and timing of neurorehabilitation, as well as staffing. Outcome assessment challenges included different outcomes collected within each setting, the timing of outcomes, and the documentation of outcomes. Education and treatment approach challenges included the communication and consistency of care amongst therapist team and care team. We have identified that every patient with stroke is considered a patient of the SKSI program. This slide illustrates the many areas where patients may enter the continuum of care to the SKSI program. Besides the patients moving through the continuum of care from inpatient to outpatient to the community, we also have patients needing access to therapy from home health and within the community or from outside providers that we need to consider into our workflow. Here is an overview of our referral sources and how we have come up to triage patients into the frequency of care they need. We created the role of a stroke navigator to assist with the transition of care of patients through the continuum. And just as dynamic are the needs of our patients in the process of their journey of recovery, we wanted to create a clinical design that meets that specific need. As a result, these paths are created to allow patients to transition through outpatient based on how they're presenting at the time clinically. What is unique about our emerging model is the customization of outpatient recovery to the individual patient's needs. We are moving away from the standard 2 to 3 times a week because that is what we've always done, or that is what staff and scheduling allows, but instead towards precision medicine with the different paths at the various frequency of care. As a team, we recognize that the recovery journey may be long for some. So throughout the continuum of care, we want the patients and caregivers to be confident in carrying over the skills they have acquired during their therapy sessions, regardless of which clinical paths they're currently in. We know that at the start of therapy, therapists do a lot more in preparation for the patients, but as a team, we want patients to be able to do more at the end of therapy sessions, which then empowers the patient further in their recovery journey. Examples we have implemented to achieve this includes family meetings and SKSI home exercise kits, both of which will be discussed in more depth in the following sessions. Our next challenge revolves around outcome assessments, where we need to establish a set of standardized outcome measures that is used across the continuum of care, as well as build an outcome database. The assessment of recovery is not only important in research, but critical to define in a clinical setting, as we want to better understand about the mode of intervention to assess its impact on recovery. Outcome measures can help define specific impairment. Once an impairment is identified, it can then further assist in clinical reasoning for treatment planning. We can use different modalities for therapeutic intervention. However, modalities can vary from clinician to clinician. For example, they can involve high-intensity training, improved cardiac output, block training, constraint-induced, or forced use therapy, just to name a few. However, as these practices do vary from clinician to clinician and institute to institute, how do we know what are the most effective treatment methodologies? For that, we need standardized outcome metrics to speak the same language and compare apples to apples. First, we needed to work on an outcome selection. For each discipline, we consulted the respective discipline-specific practice guidelines for outcome measure recommendations. As clinicians, we struggled with the time requirement of administering the outcome metrics as a potential trade-off to providing time for therapeutic intervention. At different time points of recovery, we were concerned for use of outcome measures with the potential of ceiling or floor effects. Different outcomes are designed to capture different aspects of recovery at the various time points. Thus, we needed to be thoughtful when selecting outcome measures that would provide utility throughout the entire continuum. Some of the outcome measures were novel to many of our clinicians, So for implementation, we identify champions in the acute care hospital, inpatient rehabilitation, as well as outpatient setting to learn outcome measures and to take charge of teaching the other clinicians to ensure consistency. The champions were responsible for establishing each therapist's competency and to ensure compliance. The timeline for administration of the functional assessments was an important but challenging component to address. We defined the time points the metrics should be completed. Initially, we decided upon that it would be taken on within the first week of post-stroke, and then at the first month, and again at the 3rd and 6th and 12 months. Although those time points were ideal, they did not align with our US health system constraints of health insurance requirements, and often they didn't align with patient scheduling and access to therapy. As a solution, we defined buffers that would factor in these limitations. For example, in the outpatient setting, we implemented outcome measures to be administered on the day they begin outpatient, whether it is 7 days post-stroke or 4 months post-stroke, to capture the patient's status as they enter this next step in the stroke continuum. Functional assessment selections for the occupational therapy team integrated suggestions from the occupational therapy practice guidelines for stroke for adults with stroke, and recommendations from the Stroke Recovery Roundtable. Although OT addresses numerous domains of function, such as fine motor skills, vision, and cognition, the functional assessments in the standard battery selected focused more on upper limb function as well as activities of daily living. This decision was made to maximize the feasibility of the standard battery. Now, clinicians are encouraged to assess vision, cognition, and other functional domains as appropriate for patients in addition to completing the standard battery. Ultimately, 8 outcome measures were selected to be completed across the continuum. As with occupational therapy, speech-language pathology team addresses many domains of function, specifically swallowing, language, motor speech, and cognition. As a result, the SLP team identified screening tools within each domain of SLP scope of practice through literature review. The screening tests were as follows. 1, functional oral intake scale, the FIOS for swallowing. 2, the activity measure for post-acute care, AMPAC. Applied cognition for cognition, 6 clicks, the language screening test for language, and 4th, the Diadochoke kinetic rate sequential for motor speech. And all 4 of these screening tests were completed on the initial evaluation. However, for patients with disorders for consciousness, only the functional oral intake scale and the AMPAC cognition were completed at initial evaluation. Now, if individuals scored below a specific cutoff score on the screening test, and these deficits were not at baseline in nature, then clinicians would complete the selected detailed assessment within that functional domain. Now, similarly for physical therapy, the selection for functional assessment was guided by the Academy of Neurological Physical Therapy, Stroke Edge, and core outcome measures for adults with neurological conditions and the Brain Recovery Core. The physical therapists on the team consulted with clinicians in their respective clinical setting to ensure feasibility of each functional assessment. Importantly, some selected outcome metrics had known ceiling effects, requiring the battery to have some flexibility should a clinician need to progress to a different assessment for a specific patient. So for example, if a patient achieved a score of greater than 52 on the Berg Balance Scale, clinicians were instructed to administer the functional gait assessment to improve detection of higher level balance deficits. Similarly, measures have floor effects, requiring flexibility for lower level patients. So for example, if a patient scored 0 on the first 5 items of the Berg balance scale, they were given 0 for the total score, and this will be further tracked across the continuum. Now that I have shared with you the process of how each discipline came to agreement to our selected outcome measures, the other major barrier to implementation becomes, how do we document this? And so over the past 2 years, we have made major changes to support clinical outcome measure documentation. The changes are for 2 critical reasons. First, from a clinician's perspective, having a discrete flow sheet to document outcome measures all in one place improves the clinician's efficiency with time for documentation. As we all know, efficiency will further drive compliance as it can break down barriers. The second reason for updating our EMR was to ease the data pool for future analysis. This will help us define if the interventions we are doing for patients has any impact on their impairment, activity, and participation. And finally, the education challenge, the need to create a learning network to disseminate this unified model of care focused on recovery. And this is with 2 groups of targeted audience in mind, both clinicians in their competency as well as patient self-efficacy. We needed to ensure all therapists are competent in administering the selected outcomes. So this included lunchtime meetings with in-person lunch and learns, Zoom meetings, and videos for staff to access in their own time. Competency assessments were also created to ensure consistency of administration of the selected outcomes, and established monthly audits were also put in place to ensure the carryover with the proposed workflow and integration of the outcomes into the therapist's current practice. All of these strategies were to reinforce consistency across the continuum of care and amongst the clinical team. Now, in order to build consistency of care and to facilitate discharge planning, the implementation and delivery of these SKSI home exercise kits is another example of knowledge dissemination. These specific kits were initially created for the purpose of patient care in the telehealth setting over the pandemic lockdown timeframe. But as the clinics have reopened, these kits have been adapted and integrated to patients' home exercise programs in preparation to transition to self-management and discharge. Now, each kit has specific instructions for the patient and their caregiver guided by the therapist. This is to ensure carryover of the gains that they made during therapy to home as well further into upon their discharge. The outpatient clinical team has also created a patient recovery handbook to facilitate the accountability and self-efficacy of each patient to augment the home exercise kit. So in summary, the Stroke Institute's model of care for recovery and rehabilitation really stemmed from the needs of patients and clinicians to provide better care for our patients. We needed to establish a foundation that included integration across care levels and to build an outcome database and to disseminate information through a learning network. The future plans for the Stroke Institute is to further develop an algorithm for precision medicine and further build our outcome database, as well as demonstrate the effectiveness of this model of care for recovery and rehabilitation. In order to implement this model, it is only possible from the colossal team efforts from everyone involved. This includes each clinical team of their respected practice settings and the tremendous support from leadership team, as well as faculty and administrative staff. And as always, we are very grateful to our patients that provided us with invaluable feedback. Thank you for your time and attention. If you have any questions or comments, please feel free to email me.